have the medical shelter prepared for them. In terms of fatality management, we did help out the Forensic Science Bureau. Now, Forensic Science Bureau is not a part of Puerto Rico Department of Health, contrary to what people may perceive. They are a separate bureau and they have their own policies and procedures, but under the emergency management structure and the emergency support function number 8, we were capable of coordinating help for them and support. So with the help of the federal government, several collection points for remains were placed, and these location points, they would actually pick up remains from different hospitals in order for them to be brought up to the Forensic Science Institute. At the time, we received support medical resources from the federal government. I already spoke about the medical shelters as well as those collection points for fatality management. One of the assets that we received was actually the help from the USNS Comfort. This ship was surrounding and going around the island for some time. And like I said, we were actually able to coordinate the transportation of patients into the ship. Now, one of the challenges that we faced was the idea of people who wrote out in social media, we have this ship, you can go to it. The only way you could get to it was by air. And actually, yes, the ship had so many capabilities. It is a combat ship. So it is prepared to deal with traumas, with different acute diseases. But the actual people in the island, most of the diseases are chronic. So that was a difficult part for us to explain to the population. No, if you bumped your toe, we do not need to take you over to the ship. We got those calls. My head hurts, I want to go to the ship. So that was a little bit tricky, trying to deal with the expectation. But we were able to connect with DOD, and they would actually, EMS would take the patient into a heliport, and the DOD would actually transport the patients into the ship. Now the ship were receiving patients in ventilators or patients who were in intensive care. Like I said, we also had decompression assets with field medical hospitals. One of them actually was placed at Centro Médico, or ASEM, which is our state medical center. Our state medical center is one of those hospitals that we never wanted to fall, because any condition that no other hospital is able to treat around the island goes to Centro Médico. So that was our main hub. We really didn't want it to go. And of course, people know that. So that's why many people actually went through the island to get to Centro Médico, because they thought they would get even better care than the one they had in their towns, when we were actually working to not let any of the facilities go. In terms of risk communications, even before this disaster struck, we already had different campaigns and different communications and different education levels for every type of people that we have in the island. We had flyers, we have a webpage, we have Facebook, we have Twitter, and we really bumped up our situation, because remember that we didn't have a lot of communication, not a lot of internet. People who had to go back to pen and paper. So you're going to see a picture later on in which we took out our outreach teams with flyers, educational flyers, to shelters, to different places and different communities that we were able to reach in order for them to provide. These are some examples of different flyers that we have, little pieces. Our secretary was also in the news, he was in the media, he was in the radio, as well as our state epidemiologist. Maybe not a lot, I see the heads going like this. We know it, it was not our decision, but they were able at some point to actually communicate to the public. Public health surveillance, we did try to maintain our public health surveillance in different ways. One of them was by getting to the different hospitals, like Dr. Cruz said. We had their help in doing assessments, but they weren't only doing assessments in the hospital. Our representatives on the different zones, if they couldn't reach out to a hospital, they would actually go to it through pen and paper and get their information that they were collecting for the reportable diseases. Those public health surveillance did not go down. Challenges that we had were that our hospitals were in disaster mode, so sometimes they would forget to sign the paperwork and fill them out. But that was our job to remind them to keep doing it. We also had a regional epidemiologist who were making constant visits to different shelters according to the region that they were stated into. And of course, the basic diseases that we were looking for were scabies, conjunctivitis, as well as lice. Those are the ones that they were most in contact with in different shelters. And they were able to actually educate people in shelters on how to avoid those. How could you protect yourself? There's one case from one of our epidemiologists that, and he really says it, and it really takes to our hearts because he went to a shelter, there was conjunctivitis, so he goes, he gets some drops, gets a doctor, goes, gives them the drops, leaves. After a couple of days, there's more people with the same disease. And he's like, what's going on? We brought you the medicine, we brought you the doctors. So one of our shelterees goes, and he goes, how are you doing this? How are you doing your drops? Are you putting your drops in your eyes? Yeah, I put my drops in my eyes, and then if he needs it, I'll give him my drops, and I'll give him, and they would pass drops from person to person. So anyone that had a little bit of an itch in the eye would get the same bottle. And he was like, no, everybody wait. And he actually had to do an integration and talk to everyone, let's throw away those drops. Because everyone needs to get their own little bottle. Here they are. But those are a few of the things. Right here in this picture, you see our environmental health lead, and she's actually visiting the cemeteries, because our cemeteries in those graves where they have the flower pot, those flower pots do not drain. So there was water collecting there. And where there's water, there are mosquitoes, and we have arboviral diseases. So we actually had to go cemetery by cemetery, trying to educate the caretakers, and you need to empty these flower pots. Now this is a picture of a part of our community outreach team. We had two different versions of outreach. We had our medical resource corps, who were actually providing different communities with basic emotional support as well as medical support, taking their temperature, taking their blood pressure. And people really just appreciated having someone come to the community and say, you're not alone, we're here for you. As well as the other version that we have, which you have on your right side, is the one for the community outreach, like I said, providing flyers, and educating people on different prevention. How do you protect yourself in this time of need from lepto? Please wash the cans, don't drink water that's not bottled or that's not from a certified source. Dengue, chikungunya, do not let water be collected in puddles, buckets. Please don't do that, okay? So those were the two types of community outreach. We also had our immunization program. They did continue to vaccinate different people, especially when the flu came along, because we had flu season on top of it. So we did have to do vaccinations. That would be all for my presentation, and right here you have our webpage, as well as our Facebook and Twitter accounts. You can still find information there, and it's also kept today. Our operations plans are all over the place, and any information that you need in any of our programs, you're more than welcome to look out. Thank you.
Great, thank you. Very interesting. We have two more speakers who are, I think, not going to speak directly about Maria, but talk about some work done using data to track and identify risk factors. So I'll just pull up the slide here. So our next speaker is Dr. Lin from the University of Albany School of Public Health. She holds joint appointments in the departments of epidemiology and biostatistics, as well as environmental health sciences. She's directed many environmental health studies including ones assessing the impacts of climate change, extreme weather, air pollution, and exposure to ground zero after 9/11, and Hurricane Sandy in New York. She's been involved in multiple national climate change committees on developing climate change recommendations for Congress and the President. And she's going to be talking with us about Hurricane Sandy and how we assess the impact on the spectrum of health outcomes. Sal.
Good afternoon. So I'm very glad to join this session as a panelist. So I learned a lot from the previous speakers. So today I'm going to talk about, just shift the gear like Dr. Birkhead has said, to talk about Superstorm Sandy, because it's not by the Hurricane Maria, but I think the things we learned from the previous hurricane we can learn the lesson from that. So we got multiple grants from federal governments and also the research institute to look at how the Hurricane Sandy impact the human health. So basically we have a couple aims, like we look at the long-term, short and long-term health impacts after Hurricane Sandy on multiple morbidity in New York State. Also we try to identify and evaluate some of the environmental factors change after Sandy, social demographic, community characteristics. We also try to look at how evaluate how the Hurricane Sandy impact after the home cleaning, like the oil spill, so after Hurricane Sandy. So we think this project can fill our knowledge gap by looking at the short-term and long-term health impact, and also look at the multiple health outcomes, not just one, single one, not just mental health, and also can address the critical barriers in healthcare facilities. And also the project can enhance the recovery efforts by understanding the individual, community, and also the environmental change after hurricanes. And we try to identify some sensitivity disease, so which disease is more vulnerable to hurricanes, the high-risk areas and population vulnerability. I think our next speaker will talk about more the vulnerability in community level. And finally, we try to develop some tools like the vulnerability index and predict models by use the urgent statistic methods. So the methods, we look at like the 5 counties in New York City, plus Nassau, Suffolk, and Westchester is 8 counties, affected counties by Hurricane Sandy. We also choose 2 control groups. The first one we choose, like we compare the non-affected areas control. We try to control for time-varying variables like the year, day of the week. We use the and Sandy and post-Sandy comparison because by use the same area for self-compare, so we can control for social demographics. And we look at multiple health outcomes, mental health, injury, cardiovascular disease, respiratory disease, waterborne, foodborne disease, and perinatal complications. We choose 2 control disease as a comparison, like appendicitis and cirrhosis, because they are not related to the environmental factors. So here's our results. As you can see on your left-hand side, we found by comparing different county, Bronx, which is the poorest county in New York City, has the highest the risk for the ED visit for mental health compared to all other counties. We also found among all the mental health problems, substance abuse is the major one. It's the highest proportion among all the mental health problems. If you look at your right-hand side, the top tables, you can see Bronx County have the prevalence ratio is about 782% increase after Hurricane Sandy. And we also found Queens has 147% increase for ED visit for mental health problems. If you look at the right bottom figures, we found the blue bar demonstrate the power outage, the maximum power outage proportion. So the red lines demonstrate the ED visit for mental health. So we found that after 2 to 3 days, the power outage, so the mental health ED visit reached the highest peak. So this slide tries to demonstrate the mental health ED visit by social demographic and also by disease type, subtype. We found younger age, like 5 to 19, actually is lower risk after Hurricane Sandy, but we do find elderly. Elderly definitely is the most vulnerable population, is significant increased risk for ED visit for mental health. And among all the different subtypes of mental health, anxiety has the highest risk, significantly increased after Hurricane Sandy. So this slide we got from ASPR, the grant funding, so we try to use the Medicaid data and Medicare data for elderly. We try to compare. So by use the two different reference group I just described, then we found definitely both group, the elderly people have increased risk for mental health visit. But very surprised, I want to point out here is when you look at the race, then we found compared to white, black, American, black people and also Hispanic race have a lower risk compared to the white. So now we look at the other disease rather than mental health. So as you can see on your left-hand side, we look at cardiovascular disease, ED visit, respiratory disease, and injury. So we found they all significantly increase. This is for all population, not just elderly. But we also found not just immediate effect, 4 months and 1 year after that, they still persistent increase for this other disease as well. So this slide tries to show you the Hurricane Sandy's effect on preparedness complication. So very few studies look at that angles. So as you can see, for overall pregnancy complications, significant increase for 6.3% access increase. So it's 2 days after Hurricane Sandy. Among all these multiple pregnancy complication increase, we found the highest one is the one for we call the you can see here it's 115% increase. That's very high. It's early onset of delivery, so after the exposure, and also followed by renal disease and diabetes for complications. So we conclude mental health ED with significant increase 1 to 3 days after Superstorm Sandy. And among all the Sandy-related cases, substance abuse had the largest proportion. Elderly are the most vulnerable, and anxiety ED had the highest risk. And also we recommend, don't forget about other health outcomes such as CVD, respiratory disease, injury, as well as the perinatal complications. So although the hurricane's impacts decline over time, but we do find most disease, we look at it, so the long-term trend, like 4 months and even 1 year after that. So those diseases still increase compared to the non-affected area and before Sandy. So because today's session we talk about challenges, so you can see we try to summarize a couple of things for challenges in the current disaster research. One is the significant number of residents move out of the affected area, and because we don't have a center roster for the affected residents, so we don't have a denominator to calculate the rate. So another thing is refuse rate is increased because I think especially among those they lost their family members and they have home damages, so they refuse to participate in the research. And local residents were overwhelmed with the multiple study because different agencies conduct study there. So I think some cooperation and coordination should be replaced. And volunteer bias, because it's volunteer response, so selection bias and recall bias definitely is a concern when we conduct any disaster research. Lack of objective measurement because out of power, so some of the AM monitor science is no power to run. So we don't have the objective data for that. And there's no baseline for pre-post disaster comparison. So we will address this issue in tomorrow afternoon's sessions, the same times, 2:15 to I think 3 or 4 o'clock. Yeah, in the same public health sessions. And so I hope you can join us to discuss that. So finally, I want to acknowledge my team and my students, and also especially the colleagues from New York State Department of Health, New Jersey Health Department, and also CDC. And especially also our moderator, Dr. Gus Birkhead, and he used to be our commissioner for that. So he played great leadership on that. Yeah. Thank you.
Thanks very much, Sam. final speaker, and then we can get to the discussion part of this, is Dr. Lin and Zhang. He is at the University of Albany also. He's a postdoctoral research associate at the School of Public Health. He earned his PhD in biostatistics from SUNY-New Paltz University in Guangzhou, China. His research interests include the assessment of air pollution, climate change, and extreme weather events on human health, and he utilizes mathematical and statistical models to identify vulnerable populations, most recently for the extreme weather events in New York State.
Thank you, Dr. Birkhead. Thank you, Dr. Lin, for inviting me. I grew up in an area with catastrophic storms every year, and they blew away our roof and took away all our vegetables and seafood, and sometimes brought the fish from a river to our home, and they were flooding. And so I was so scared when I was a kid. Today I'm going to talk about how community vulnerability factors jointly affect multiple health outcomes after catastrophic storms. Over the past decade, there has been an increase in hurricanes and superstorms across North America as a potential result of climate change. Growing efforts are being made towards identifying vulnerable groups for emergency preparedness. Among these existing studies, the majority evaluated vulnerability variation across individual factors like gender, age, and other social demographic factors. Understanding the individual vulnerability is important. However, evaluating the community vulnerability and identifying special hotspots at the highest health risk are of greater public health importance. However, there are very limited studies evaluating the community vulnerability. These limited studies usually develop a vulnerability index to represent the population vulnerability based on numerous community factors. However, they left multiple additional knowledge gaps. At first, they didn't consider the direction of the impact of these community factors. All variables were assumed to be risk factors, increasing the vulnerability of population. I mean, all the variables represented the low socioeconomic status. They were assumed risk factors. And second, the weight for these community factors were not considered. All variables were assumed to be equally important to the population vulnerability. And actually, no specific exposure events or health outcomes were considered in the existing vulnerability index. To address these knowledge gaps, we designed this study to identify community characteristics that contribute to increased vulnerability. And we developed a novel community vulnerability index by weighting selected community factors with their contribution to the vulnerability. And we evaluated the vulnerability of affected residents by monitoring health outcomes during Superstorm Sandy, one of the most destructive storms in the U.S. history. We include cardiovascular and respiratory diseases, intestinal infectious diseases, mental disorders, and injuries. Since these outcomes, based on literature review, were the major disease grouping are related to the storms. And their association with the storms are biological possible. We first determined the association between each health outcome and the sandy exposure for each of the 3,000 census tracts. With time series analysis, we use distributed non-linear model to capture the cumulative health effects during and after the storm. We also control some time varying confounders like weather, air pollution, and other like holidays. We determined we defined that census tract with the risk ratio significantly greater than 1 as the risk elevated communities, otherwise as risk non-elevated communities. We regress the risk elevation status against all these all these community vulnerability factors, including the proportion of residents below poverty and the proportion of those unemployed and the average income of the community. We use the machine learning method to get rid of collinearity issues and outliers, something in the data. In this step, we determine the contribution and the direction of each community factors on the population vulnerability. Finally, we develop the index by summing up these community factors weighted by their contribution and directions. And we validate our index with our C. This table describes the contribution of these community factors on the elevated health risk immediately following the storm. For each of these health outcomes, we found positive overall contribution to increase the community vulnerability to multiple health outcomes except the respiratory disease, which is negative. And we found that socio-economic factors had a larger contribution on injuries and substance abuse. We found that factors in minority status and language domain, as well as those in housing and transportation domain, had a larger contribution on respiratory disease, cardiovascular disease, and mental disorders. This table describes the contribution of community factors on the health risk in the first year following the storm period. We only found a 1 year longer term vulnerability for mental disorders, substance abuse, and intestinal infection disease, not other health outcomes. The patterns for the contribution of community factors were similar between these health outcomes. And for each health outcome, most of the factors were associated with an increased community vulnerability. We can see all these contributions, most of these contributions are positive, particularly those with a larger contribution. We developed the community vulnerability index for each sense check and for each health outcome. The area under the ROC curve confirmed that the new community vulnerability index, no matter based on selected variables or based on all variables, are better than the index developed based on following the existing methodology, represented by the social vulnerability index. In summary, we found that community vulnerability during superstorm study could be quite different and even vary in direction based on health outcomes. We found that injury, substance abuse, cardiovascular disease, and mental disorders increased more in communities of less optimal social environment following the storm. But we found that respiratory disease increased more in optimal social environment. And we found that socioeconomic status, housing, and transportation factors may have the largest contribution on the vulnerability to multiple health outcomes among all four domains of factors. Specifically, we found that low per capita income, the percentage of population without a high school diploma, and the proportion of those living in multi-unit structures and group quarters like housing facilities, they are the dominant predictors of the population vulnerability. We observed the short-term vulnerability for all outcomes except the intestinal infection diseases. And we found only longer-term vulnerability to mental disorders, substance abuse, and intestinal infectious disease. We found that the new community vulnerability index tend to be more robust and better predict performance than the existing indexes. In summary, we found that substance abuse, injury, and cardiovascular disease as mental disorders were sensitive to many less optimal community indicators after the storm, enormously of the respiratory diseases. We found that low per capita income and the percentage of low educated population, or those living in multi-unit structures or group quarters, or the dominant predictors for community vulnerability. And among all the outcomes, we found both short-term and long-term increased vulnerability for mental disorders, and we found the long-term vulnerability for intestinal infectious disease only, and we only found the short-term vulnerability for all others. The new community vulnerability index based on this information has an appropriate predictive performance. Thank you for your attention.
Great, thanks very much. So I'm going to ask our speakers to all come up to the front here, and we're going to open up for some questions and discussion from the group. And maybe I can start off. I think a number of our speakers touched on the need for public health response for in the areas of chronic disease, mental illness, substance abuse. I think the general public, when they think hurricane, is thinking, oh, trauma. We need to be able to prepare to deal with trauma. But I think pretty much all the speakers focused us in a different direction. And I guess my question is, in terms of our response planning for future storms like this, what's the balance between being prepared to deal with trauma, acute problems, and the longer term? How can we be prepared to deal with the longer term problems of chronic illness, renal disease was discussed, people in need of dialysis, ventilator dependent patients, but also the long term mental illness. It seems that we should be building that into our response plans as well, more based on everybody's discussion. So I'll just open it up to whoever wants to start with that.
So I'll start with that one. The Puerto Rico Department of Health efforts after Maria, even before we were going in that direction, but after Maria we saw a basic need to actually sit down with our peers and different core advisory groups that actually work with these types of patients in order for us to help them better prepare themselves. We have seen throughout the entire course of all of lectures and meetings that we've had during today and even yesterday night, in which we do need to make our own communities more resilient. As people get better prepared and they better know their own conditions and their own chronic conditions, and what may be the consequences of not following like a strict diet if it's needed, or if you live in a vulnerable place and you're a dialysis patient, what the need is for you to actually move to a temporary shelter because the roads and the access might be limited. And that's something that we've been really trying to. We do know that dialysis groups, they are also making their own plans and emergency plans to better detect these patients, where are you, and track them down. They always do try to give dialysis prior to the event. If it's a hurricane, they already know it's coming. And actually during the summer, and I will give you an example for that, we were having these big protests during, and they were against the government. Dialysis clinics actually went ahead and did dialysis